Peter.
Peter.
Thanks for
So I'll
working together
briefly
on this.
introduce Sue Pedersen, who many of us already know, a friend and a colleague of all of us at LMC. She's also a specialist in endocrinology and metabolism, as well as obesity medicine, practicing at C-Endo Diabetes and Endocrinology Clinic in Calgary, actively involved in most of the obesity and type 2 diabetes trials, serving as a PI, national lead investigator, and global panel member on several studies, and of course, actively involved in the obesity clinical practice guidelines, both the previous iteration and I'm certain future iterations to come. And obviously, everybody's now all knowledgeable endocrinologists when it comes to vaccines. And so we're thrilled to have you tonight, Sue, to talk to us further and kind of bring it home for us on the specialty side of things.
Awesome. Thank you so much, Alex, and thank you for having me, and thank you to everyone for spending your night with us. I don't know about you guys, but I feel just so inspired by how Peter started us off to really help us to understand how these vaccines work, the powerful efficacy that they provide, and really how far they can go to helping to protect our patients. So let's now talk about our patients. I really want to dial in here on the specialist role. So us as endocrinology clinics, what is our role in optimizing immunization in our patients? We're going to focus on patients with diabetes tonight, but we can certainly talk about other comorbidities as well. So these are my disclosures related to my research involvement and my teaching involvement domestically and internationally as well. So in the next half hour, 35 minutes or so, I'd like to take us through, first of all, recognizing the burden and the impact of viral infections in patients that we see in our clinics every day, patients with cardiovascular disease, chronic kidney disease, diabetes, and so forth. I want to talk about the bidirectional relationship, this vicious circle between viral diseases and these chronic health conditions and how this impacts the outcomes to our patients. And then really want to have a conversation, and I think Alex will lead a conversation afterwards amongst us as a group. And I can certainly share with you some of the things that we've implemented at C-Endo to really optimize the conversation and get the word out to patients and get those vaccinations into arms. It's really our responsibility. It's not just something for the primary care physicians to do. It's something that we all have to do in the medical community. So we'll come back to that. And we always, of course, want to learn in the context of a real life clinical case. So when we have a patient coming to our clinic tomorrow, you're going to meet Sonia. Sonia will be in all of our offices tomorrow. How is this information going to apply to Sonia in our practice, coming into our diabetes educator, coming to our pharmacist, coming to our endocrinologist? How is Sonia? How are we going to do things differently when we see Sonia tomorrow than when we saw Sonia today? So she is a 56-year-old lady. She has type 2 diabetes. She has stage 3 chronic kidney disease. She used to smoke. Thankfully, she quit. She also has obesity. And she had pneumonia after the flu a few years ago. So she wasn't really much of a flu vaccine, kind of wasn't really into that. But now that she's had something bad happen, as is so common as we as humans, going forward, she gets that flu vaccine every year. And she's gotten her COVID vaccines, but isn't really, she thinks she's probably up to date on her vaccines, but nobody's really talked to her about it before. So she's taking the medications that we would commonly see in a patient like Sonia. She's on semaglutide, basal insulin. She's on her vascular risk protection strategies. We're going to come back to that. Remember those words. Atorvastatin, her ACE inhibitor. She's on metformin, and she's also on an SGLT2 inhibitor. Awesome. She's got a GFR 52. She's got little albuminuria, and her blood sugars are actually, won't talk about it today, and I'm a little nervous she might be having some lows being on insulin with an A1C of 6.5, but that's not our discussion for tonight. So we've got some polling for you, and Nikki, thank you. Oh, she magically launched it, but she knew what I was thinking. So based on your current knowledge and what we've learned from Peter, what vaccinations would you recommend for Sonia? And you should be able to pick, not sure if you can pick multiples or not, but just give it your best, give it your best shot and tell us what you think. It actually is a single choice, so you have to pick one, looks like. All right, can we share the results? I see
Should be
one.
able to see them now.
Yeah, I see one for influenza. I think that must be wrong. Can you see them?
Yeah, it's 1 out of 6 for influenza, 5 out of 6, all of the above.
Oh, there it is. Okay, got to scroll down. Okay, yes, perfect. So most of you said all of the above, and that is the correct answer. Let's talk about that. So it's really important to know that acute infections with influenza or RSV and herpes zoster episodes as well are associated with important long-term complications. We tend to think of influenza and RSV that can be complicated by pneumonia, and that's true. But what we don't really think about is that all three of these viruses are associated with a higher risk of stroke and myocardial infarction. And RSV is also associated with a higher risk of congestive heart failure subsequently. So these are not traditional things that we think about as complications of these infections, but they're very real, and there's good data to support that. When we look at RSV and compare it to influenza, so we're pretty familiar, confident with influenza and flu vaccines. If we look at the bad things that happen with RSV, the rate of complications and mortality in adults hospitalized with these viruses are actually quite similar. So if we have RSV here in the blue, influenza in yellow, we see that we have similar rates of lower respiratory complications, bacterial superinfection, the cardiac complications that probably haven't been thinking about enough, and hospitalization, readmission, and death during hospitalization. So we really need to be thinking about RSV vaccination in a similar way that we think about the importance of the flu vaccine. Older people with chronic medical conditions, and again, these are our patients, guys, they're at a higher risk of vaccine preventable disease and complications related to infection. So we know that as we get older, as you heard from Peter, that there's a decline in immunity via immunosenescence or immune aging. And there's a greater likelihood also of having a chronic inflammatory state, low-grade inflammation. Often that's associated with obesity, also can be associated with other chronic medical conditions. And this can portend an increased risk of more severe viral infections. Many people who are older also have chronic medical conditions that contribute to inflammation and immune dysregulation, like in relation to type 2 diabetes, obesity, chronic kidney disease. Oh, Sonia has all of those medical conditions, further exacerbating her risk. Older people are at a higher risk of complications from viral infection, like pneumonia, stroke, MI, and if they're admitted to hospital, they also have an increased risk of nosocomial exposures as well. So you layer that on top. All of this puts our patients with comorbidities and our older patients at higher risk as well. So if we look now individually at patients with cardiovascular disease, people with diabetes, and people with chronic kidney disease on the right, we see that all three groups of patients are at high risk of morbidity and mortality from infectious diseases. And again, many of our patients are going to have overlap in terms of having more than one of these health comorbidities, which further compounds the risk. So for example, all of the groups have a higher risk of having a shingles episode, and all of them are at higher risk of hospitalization with RSV. So how does this inflammation and immune dysfunction related to underlying disease and acute infection contribute to severe vascular outcomes? Well, in the setting of cardiorenal metabolic diseases, patients have reduced activation of innate cells, reduced expression of antimicrobial peptides, increased inflammation, and so forth. If we then have an infectious agent in the patient, there can be a systemic effect, including increased inflammatory cytokines, increased heart rate from that adrenergic state, they're sick, adverse effect on lipids and their ability to adhere to the endothelium, along with direct vascular effects, including platelet aggregation, increased inflammation, and potential for thrombosis or clotting. So we can see how all of this together, this vicious storm, can increase the risk of severe outcomes like a cardiovascular event. So there's a bidirectional relationship, as I mentioned in the objectives, and this is really a key point. between viral diseases and complications associated with chronic conditions. So if you have a patient who has chronic conditions or comorbidities, this increases their susceptibility to infection and severe outcomes from RSV, influenza, zoster, COVID, and in turn, getting one of these viruses can disrupt or exacerbate the comorbidity. So you can get deterioration of glycemic control. You can get a cardiovascular event, a stroke. You can get deterioration in renal function. So this becomes a vicious cycle, which we can break with the power of vaccination to help to eliminate or reduce this vicious cycle from happening. So to look at what we know from influenza, I kind of like to, a few times tonight, I like to kind of back up and go, okay, let's talk about the flu and put it in context, because we're really comfortable with the flu for years and years. So from looking at what we know from influenza, it's really clear that preventing infection through vaccination has helped to reduce the risk of longer-term health complications from the flu. These data are particularly robust in older adults and in people with pre-existing comorbidities. So again, our patients at our endocrinology clinics. I understand there's some cardiologists on the line as well, and this would include your patients too, absolutely. So some of these benefits can include a reduction in going on to dialysis if you have chronic kidney disease, a reduction in mortality in people who have end-stage renal disease, reductions in mortality, reductions in cardiovascular events, heart failure-related mortality, CVD, and the list goes on. So I really feel that this is compelling to show us when we're talking about the flu vaccine that this is actually a vascular risk reduction strategy. And this brings me to probably one of my biggest key messages from tonight, that we need to be thinking about vaccinations on our vascular protection checklist when we're going through that in our head. And I always do this when I say this because, you know, we're all sitting with our patients in the office and I have like a little cartoon checklist up here on the right side in my brain going, okay, should my patient be on a statin? Should they be on an ACE or ARB? Make sure that they're not smoking. Are they on a GLP-1, an SGLT2, finerenone, icosapent ethyl? The list gets bigger, right? We need to be including vaccinations on our vascular protection strategy checklist. If we look at influenza vaccine and CV events, meta-analysis shows a 26% reduction in MACE and 37% risk reduction in CV death with the influenza vaccination. And, you know, can we extrapolate? We don't have data for the other vaccines to show what is the risk. Is there a reduction in MACE? Is there a reduction? We don't have cardiovascular outcome trials for vaccines, but you know, again, when we've heard from Peter, we've heard about the vaccine efficacy and the very low risk associated. And we're not talking about medications that patients need to take every day or every week and pay for on and on and on and on, which are the medications we're comfortable advocating for as our vascular protection. These are one injection or two injections and you're done. It's very easy to get the patient to adhere to that. So we don't have problems with, you know, pill burden and, you know, treatment fatigue and all of this. It's easy stuff to do. So despite the global recommendations, vaccination coverage is still really low, especially in high-risk groups. So we have a lot to do as a community, and there's just it's low-hanging fruit to introduce routine vaccination counseling into our clinics, prescribe vaccines, and get more people vaccinated. So here we see the course of time from 2006 through 2021 on the x-axis, and then we have the vaccine uptake represented here in the bars. So the vaccines are color schemed. You can see that on the right-hand side. And we have at the top the National Immunization Strategy recommendation to get at least 80% of people age 65 and older, as well as those less than 65 with high-risk conditions immunized. So that's sort of like the benchmark. Like, let's try to at least get there. And look at how far below a lot of these vaccines are falling. The influenza is the one that gets closest to this bar. That's the dark blue, around 70% in age 65, with influenza in younger people at high risk falling much short of that, actually, only around 40%. We have pneumococcal in green and blue. Here again, we see it falls very much short of the Canadian recommendations. Shingles vaccine, also NACI recommended, is here in pink and also falls short. So we have a lot of work to do. So back to Sonia, she's back in for a visit, and she mentions that her husband had just had shingles and he was in a lot of pain, missed several days of some dialysis sessions. He's got end-stage kidney disease and he hasn't been able to function independently. So now her husband is dependent on her for all of his care. He can no longer care for himself. So we see this again and again, this terrible, terrible impact that having shingles has following, and it can last the rest of that person's life, and it affects their family as well. So Sonia is now worried about herself getting shingles. She wants to know if it's contagious, and she wants to know if she should get a vaccine. So first of all, Sonia's got type 2 diabetes. Does that put her at risk, increased risk of zoster infection compared to the general population? We can certainly tell Sonia that 99% chance she's already got the virus in her body. It's not going to be contagious from her husband to get the shingles, but she has it inside. So in a sense, it's kind of like contagious from yourself. So let's talk about how we can prevent that. And Sonia, as you've heard from Peter as well, that people with diabetes are at higher risk of having zoster. So you've seen already this figure from Peter on the left showing that as we get older, that risk of shingles goes up. But actually, 1 out of 3 people who get shingles in Canada, it happens under age 50. So 2/3 over 50, 1/3 under 50. And if you look at diabetes, we have about a 24% increased risk of having shingles compared to someone who doesn't have diabetes. So we can tell Sonia, it's not contagious from your husband, but you have the virus inside you yourself. You are at higher risk because of your diabetes, your chronic kidney disease as well. So let's get you vaccinated. So again, here we have this bidirectional relationship. So not only does Sonia have a higher risk of having shingles because she has diabetes, but the shingles in turn is associated with a risk of deterioration of glycemic control. So about a quarter of people with diabetes who get shingles have an increase in their A1C based on a retrospective study. I would say from my experience, I think it's probably higher than that. But not only that, but people with diabetes can have glycemic deterioration long-term because of postherpetic neuralgia with pain and discomfort driving sugars up. They may have impaired wound healing from the sores that they develop with shingles, and there's an increased risk of hospitalization, and the intense pain can impair mobility and daily functioning, as it's done with Sonia's husband. That's the last thing that we need to have happen in our patients. So here's some data looking specifically at the relationship of zoster with increased risk of cardiovascular and cerebrovascular events after having a shingles episode. So if we look at cardiovascular events here, we see that 3 months after having shingles, there's about a 31% increased risk of having a CV event. And if we go out to a year later, there's still about a 12% increased risk of having a cardiovascular event. If we now look at cerebrovascular events or strokes, we see that 3 months after having shingles, there's a 34% increased risk of having a stroke, and there's still a 40% increased risk a year later. So that's a sustained risk even out to a year. And we'll talk a little bit more about the pathophysiology behind this very important and very interesting data that, again, I think is really under-recognized. Okay, so get out your polling, get out your phone. Don't get distracted by Instagram or YouTube Reels, but let's just focus on the question. So Sonia's got stage 3 CKD, and this increases her susceptibility to viral infections. So what do you think is the relative risk increase of zoster in patients with CKD compared to the general population? I think I alluded to some of this already.
You didn't make it easy, Sue. Very close.
Okay, we got a 50-50, looks like, for C and D. Great. Okay. So the correct answer is actually was about 28 to 40% increased risk. So people this is people, again, with chronic kidney disease, 28 to 40% increased risk of having shingles because they have a background CKD, so they're predisposed. And conversely, shingles increases the risk of faster GFR decline and even end-stage kidney disease. And that may be related to the inflammatory state that is generated by a zoster infection, or possibly related to dehydration when patients are ill with shingles, so taking an acute on chronic hit because of pre-renal failure or dehydration. So people with underlying comorbidities, again here, similar theme as what we have seen with zoster, also have a higher risk of severe RSV disease. So if we look at hospitalization rates for RSV in people age 50 or older, we see that compared to people without a health comorbidity, people with asthma have about a 3 times higher risk of hospitalization. People with diabetes, 3 to 6 times higher risk with coronary artery disease, heart failure, and especially COPD. And we already heard from Peter about the risk of death for older people admitted to hospitals, about 1 in 9 if they get admitted with an RSV infection. Now, if we dial into patients with heart failure, for the cardiologists in the audience and endocrinologists, there's lots of heart failure patients in our office. We're learning this more and more, right? We see that these patients have 8 times higher risk of hospitalization from RSV compared to adults without heart failure. 20% of elderly people with RSV infection had a hospital discharge diagnosis of heart failure, and about 5% of all heart failure admissions during viral season were attributable to RSV infection. So again, I think what we're seeing here is reflecting both that RSV infection can lead to an exacerbation of heart failure, and again, that bidirectional relationship. Patients with heart failure would likely have a higher risk of severe RSV. I actually think I don't think I have included here the slide about the inflammation and pathophysiology. So I'm just going to verbalize that for a moment. So you might be wondering, so how come, why do patients have a higher risk of heart attack and stroke? And we believe this comes down to inflammation. So inflammation of the lining of the endothelium, as we talked about earlier, increasing the risk of thrombosis. So I just wanted to come back to that again to really help us understand that people are at higher risk of vascular events when they have these infections, with that background issue being that chronic inflammation. Okay, so how do we now, as endocrinology clinics, cardiology clinics, specialty clinics, how do we integrate vaccinations as risk-reducing strategies in our patients, in our clinics? What do we do? So Sonia, let's come back to her. She mentions that her family doc is kind of hesitant to recommend the zoster vaccine or the RSV vaccine without us, the specialist care team, recommending it, because she's got complex medical issues and her family doc's not sure if this is going to be safe or effective. And we do hear patients say that. So again, not only are family doctors just as busy as us, probably busier than us, they are also time limited. We cannot just insist that primary care takes care of all of this, and they may have some uncertainties as well. We have patients who are polypharmacy. They've got, it takes us an hour to go through a good, thorough clinical visit. They've got 100 different things going on, and the family doc may just say, you know what, this is I'm nervous. I'm not sure what to do here about anything for your health. Please go and talk to your specialist because I'm not sure what to do. So this brings us to overcoming barriers to vaccinations. So there's a number of barriers or reasons why Canadians are so under-vaccinated. And this is actually some very interesting survey data asking patients about vaccinations and why they hadn't been vaccinated. So actually, interestingly, 9 out of 10 thought they were up to date on all their vaccines, but only 3% actually were. So there's clearly an educational barrier here in patients not knowing what they should be getting. The number one barrier is that vaccinations are not being recommended by healthcare professionals. So patients described, well, I didn't think it was necessary. The doctor didn't mention it. I've never heard of it. Cost can be a factor, yes, but it's actually only seen as a barrier by about 19% of people. So the dominating theme here is that patients aren't being recommended to have the vaccinations. It's not being talked about. So it's really up to us as specialists to take ownership, to recommend vaccines and prescribe vaccines to our patients. Our patients are the ones who have the higher risk and really can stand to benefit from these wonderful vaccine tools. If you even look at the flu vaccine, it's kind of upsetting that a third of patients don't remember even being told by any healthcare provider that the flu vaccine is important. Many people say they would be more likely to get a flu vaccine if a healthcare professional recommended it. These principles apply to the vaccines that we've discussed today as well. It's not enough to expect family docs are going to do all the recommending and all the prescribing. In fact, we know that many Canadians don't even have a family physician. So just think about the patients you've seen this week and how many don't have a family doc. All of us have seen patients like that. They don't have a family physician. So we can't say the family doc's going to do it if they don't have a family doctor. That makes no sense. We also know that if a patient hears messages that are consistent amongst their various healthcare professionals, they'll be more likely to follow through on that recommendation. So if they hear it from us, they hear it from their family doctor, they go into the pharmacy and the pharmacist says, hey, I notice, you're not up on your vaccines. Can we talk about that? Or, gee, did you know the new COVID vaccine just became available, and the flu vaccine and RSV and shingles? Let's talk about them all, and we can give you multiple vaccines at once. It's really easy. This is how we can get patients engaged and get them vaccinated. So you've heard some of the recommendations from the immunization bodies in Canada already from Peter. Just go over a couple of things here. So we've got NACI, which is the Canadian, and ACIP, which is the American. And I'll just focus on the RSV and zoster vaccinations we talked about tonight. So in Canada, as you heard, RSV is recommended in anyone age 75 or older, and age 60 to 74 in long-term care. And as you've heard, there's some provincial coverage now in these groups. So Alberta, Ontario, you've heard that from Peter already. In the US, these recommendations are extended to people 60 to 74 at risk of severe disease, including those with diabetes and end organ damage and those with chronic kidney disease. And I was really pleased to see that obesity is now also considered a risk factor for severe RSV disease, warranting vaccination. Specifically, the guidance currently includes people with a BMI of 40 or higher. And this is kind of how it started with COVID and understanding that obesity is a risk factor for severe COVID. And the guidance then came out that BMI of 40 or higher are at increased risk. And then we learned over time that people with obesity with a BMI lower than 40 were also at an increased risk. So I'm really pleased to see that obesity is now being brought into this circle. Obesity is a state of chronic low-grade inflammation, and we know that that's some of that baseline issue that puts people at risk of more severe reactions, reactions to infection, or more severe infection. For the shingles vaccine, this was recommended in Canada for anyone age 50 or older, and is also indicated for people age 18 or older who are immunocompromised or immunosuppressed. Now, what about our diabetes guidelines? Well, the American diabetes guidelines are more updated than ours are. They recommend the vaccinations as you see on the screen here, so quite comprehensive. Focusing on tonight's conversation, they recommend RSV for people age 60 and older and shingles for those age 50 and older. I suspect that when our Diabetes Canada guidelines are ultimately updated, they will likely follow the recommendations from the American in the ADA as well, but they are 6 years older than the ADA guidelines, so they do need some updating. So what can we do in our clinics to optimize the immunization rates in our practice? So let's now talk about what's actionable here. What can we do? So first thing we can do is make whatever we do routine. So we want to make a habit about talking about vaccination. We can have patient handouts. We can have posters on our wall. We can have our own checklists to be talking about it. We can put it in letters back to the other specialists, to primary care physicians. We can have our allied health teams. I know we've got lots of pharmacists here on the call. You guys are one of the most important resources in vaccinations, that you are so great to talk to patients about the different vaccinations, and you can see what they've had and what they're missing. So whatever we do, it needs to be a habit, and we really need to all take the responsibility for the discussion. We can't be pointing like this to everyone else. We all need to point at ourselves. So ourselves endos, ourselves pharmacists, cardiologists, family doctors, everybody needs to take the responsibility. Don't assume someone else is going to do it. Second thing we need to do is make it clear. We need to not just say, yeah, so have you had your vaccinations? Talk to your pharmacist. We want to make it clear to our patients. It doesn't take very long. Help our patients to understand we have all these strategies, all these medications and tools in place to optimize your health, protect your heart, protect your kidneys. We've talked about this many times before with our patients. So all we need to do now is say, and vaccinations to protect your health. And here's how it can protect your health. And the risks are very low and the benefits are huge. And you've heard the numbers from Peter already. It doesn't take long to have the conversation. Help your patient to understand why, rather than just saying, you should go get a vaccination, it's good for your health. Help them understand. Did you know that there's a higher risk of having a stroke after you've had shingles? Most people don't know that. Most doctors don't know that. So we want to help them to understand. And finally, we want to make it easy. So whatever system we put in place, we need to make it very straightforward. We want to make sure patients know where they can go to get their vaccine. We can pre-populate the vaccines into our electronic medical record. So it's just a click and a print. We can add vaccination prompts to the EMR. And I know, Alex, you wanted to take some time to talk as your team about how you can take responsibility for that discussion and how you can build a habit and build it into your systems to make this something that is very routinely done with your patients. So take-home messages is that we as specialty care teams can recognize that patients with comorbidities are at higher risk of developing zoster and RSV infection. They're at a higher risk with more severe outcomes, including risk of cardiovascular events and stroke, and that those conditions or those having the infection conversely then can cause more problems with our patient's medical issue getting out of control. And I like what Peter said about it actually being a time-saving thing for us. You talk about vaccines, get your patient vaccinated, and then they're not coming back to you and calling you because their sugars are 18 and 20 because they now have shingles. And what do I do with my insulin? Because they didn't get shingles because they got vaccinated. We can play a unique role as specialists. We're in a wonderful position here, low-hanging fruit. We love low-hanging fruit. We can highlight that potential risk reduction and benefits of vaccination for our patients, help them get vaccinated, so easy. Recommend. Remember, we want to make it actionable. We want to recommend the vaccination. We want to write the prescription to reduce the risk of outcomes and attenuate potential complications. So vaccines are simple, they're safe, they're efficacious, they're quick and easy, they're durable interventions, and they can go so far to better optimize the care for our patients with comorbid conditions. And finally, if you want to send your patient somewhere to read about it, if you feel like you're busy and you don't have a lot of time, this is my website. You might have seen it before. I've got over 3 million hits. It's read quite widely. One on the RSV vaccine and one on the shingles vaccine. So you can just search in the top right, and it's written for healthcare providers, but also at a level that patients can understand. So I welcome you to enjoy that. Thanks so much.
Thanks, Sue. Great presentation, as always. We'll open it up like we did last time. And are there any questions? I'll tell you what impressed upon me the first time I remember hearing about this conversation was that real bi-directional relationship that you touched on. We're obsessed with outcome-driven care, SGLT2 inhibitors, GLP-1. We forget about the precipitant. And how often is that heart failure episode, not just you're walking down the street with heart failure and then all of a sudden you end up in the ER, but it's the flu or COVID or RSV that, kind of sends you snowballing. And yeah, I'm with you. It's not often in the framework of my thinking. IPE always also, but probably should be raised higher. But there's a lot, right, of outcome-driven methods and lots of different layers of therapy. And maybe we should add a V to the vascular protection checklist, as you alluded to. I know they're not redoing the vaccine chapter, which is a very brief chapter of Diabetes Canada that really just points to the NACI guidelines.
Yeah, and we need to not, guidelines, as a guideline writer myself, I believe very strongly in guidelines, of course. but by their nature, they're already outdated even by the time they get published, right? And then if they haven't been written again, we can't go, oh, well, Diabetes Canada doesn't really say that we should, but well, they're from 2018, right? So if we're just looking at the guidelines and just zooming in on that, saying, well, that's okay, that's not our job because Diabetes Canada doesn't say that we should be, but that's not acceptable, right? The guidelines are outdated and the data is there. And, I think the other thing is that we can feel overwhelmed, right? When we think, okay, one more thing, we talk about our vascular checklist that now includes SGLT2, GLP,
Mhm.
finerenone, icosapent ethyl, on top of all of the old stuff. You can feel like, oh my goodness, like I do not have time to talk about one more thing. I'm screening for sleep apnea. My patient's depressed and I've got 4 sets of insurance forms to fill out. But if you think about the time that we readily dedicate to talking about, oh, my patient stopped their statin. And why did you stop your statin? Okay, you ran. Okay. And well, you don't believe. Well, let's talk again about the
Yeah.
importance and what they can do. I probably talk about that, once every couple of years with my patient because they need to hear it again because they stop being
Mhm.
compliant with it. We can spend just a little bit of time for this massive benefit. It's actually way out of proportion in terms of efficiency to talk about vaccines than it is to talk about all the other stuff that we spend so much time without question talking about. And I'm not saying we shouldn't talk about those things, of course, but it's really small, small time for big, big benefit.
Don't worry, lipid lowering vaccines, sort of the one and done treatment you might be looking for, is in the works. So we'll keep plugging away at that. But for now, yeah, statin adherence, very important.
Yeah.
Good. Well, I'll take the liberty, obviously allow myself to just share the screen. Since we have endos and we have Sue, who already alluded to that, there's been some maybe steps that they've taken at C Endo to really make this top of mind or one of the top of mind aspects of diabetes care. We have pharmacists, we have PAs. So I open it up. Obviously, we'll start, just by asking Sue if you wouldn't mind, as you alluded to it, what kind of steps or pathways or anything, have you guys sort of implemented that you found successful?
Well, it's a process in evolution. I think we're growing I wouldn't say that we have a completely seamless, I mean, nobody's perfect and everything's a work in progress. But so we have macros in our EMR, right? I've written and that we share, where you can have a macro that you put in your letter for, I have recommended this in this vaccine and I've discussed the benefits and risks. So all of that's there. And then you just spend a few seconds to talk to the patient. If you're out of time, and that happens, right? I just don't have time, and at least then you can put it in a letter. So we've got another macro that we can be one to for the family doctor, and we try not to use that punting. I'll call it the punt macro. We want to take ownership ourselves, but it's better than nothing. We have all of our, as you guys are doing tonight, and which is wonderful. All of our allied health have it on their checklist to talk about with the patient when they're in seeing our diabetes educators, our dietitians, and so forth. So we've widely educated all of our team about it. We've been talking about patient handouts. We used to do that actually before COVID, and now we've got to figure it out with all this virtual medicine. We actually used to give them a little slip about getting vaccinated for, flu and pneumococcal and so forth as they were walking out the door. So we've been talking about how we might integrate that with virtual medicine as well. I'm not sure we've quite figured that out yet, but those are some ideas.
In my own head, I still, I have a hard time kind of grouping them together. I see, the seasonal flu vaccines. And I was telling Sam, we're texting each other while you were speaking, that what if you don't see your family doctor during flu seasons? Does that mean if
Mhm.
you have, the April appointment that you're just destined to never have a conversation about COVID or flu or RSV with your family physician, but you see your specialists a little bit more often? The nephrologists are commonly telling us that every dialysis patient is, they're their family doctor because they're already coming in for dialysis. Not something we ultimately do all that much in endocrinology. And then you're sort of one and done vaccine. But your patient that's most vulnerable and obviously wanting to it, did they get it? Did they forget that they get it? The idea of, the onus of who's responsible for this vaccine. I agree with you. You don't want the punt macro. I'll be the
Mhm.
first to admit I use the punt macro all the time for my diabetes patients. I'm trying to stop. Still an important punt macro. But yeah, I would say the pathway in progress. I'm curious. I don't want to pick on our pharmacists, but I am curious since you guys do med checks. I know that there's A, B, C's often, incorporated into the letter, and you guys are referencing the vascular protection checklist. Are vaccines discussed with our pharmacy team?
They are on our checklist, and it's something that they are part of our complete ABCDEs of diabetes form. So it is something we usually go over. I think it's just kind of missing the next step of we talk about diabetes, we talk about vaccines, but then we don't necessarily always take action based on that. So I think that's sort of the missing step.
Well, that's partly true because I would say COVID and flu, you guys are taking those steps.
Yeah, for
You
sure.
reach out to the patients, you recommend it. But yeah, that extra step where a prescription is needed, that I agree with you. I think that's why we're having this discussion. That was Jessica Liu. She's director of LMC pharmacy across all of our sites. For those who don't know Jessica, thank you for that. So I guess the big
Um,
question, which we're obviously opening up to anybody here, physician, non-physician, do you already incorporate vaccines or vaccine discussions for diabetes patients in routine clinical practice? We heard, it's touched on as part of the med checks. Sam and I, we're going to work on some handouts like Sue, hopefully, something that we can incorporate because yeah, many not even aware that these vaccines are aware. I remember reading some of the Health Canada stats myself, and I think there's something like 40% of people who don't even know what RSV is, and the majority still think it's a pediatric disease and really doesn't affect the elderly outside of babies. So really, it's an uphill battle for vaccines if people don't even know about the disease.
Something I just while you're percolating on that, I I didn't want to emphasize it too much because I know things are different in Alberta, but you have an Alberta site as well.
Yeah, of course.
We rely very heavily on our community pharmacies and pharmacists to do a lot of the vaccination counseling, and they can also prescribe, just as long as it's on label, right? So we actually have the co-op pharmacies in Calgary. The Calgary co-ops have this program they've set up called the Co-op Hub program, and there's a checklist where they can help with GLP-1 starts or Repatha Ready program or whatever. And we asked them to put vaccine counseling on this checklist, and we can literally, they said, just write it. You can be sending in a prescription for insulin, and on that you can say, and please do vaccine review. And they will take care of everything. And they can also prescribe the vaccines, which we're very fortunate that they have that prescribing latitude in Calgary or in Alberta. But if that helps, that would be the one thing that I rely on the most, because it's really easy for me to do. And please do vaccine counseling on my prescription. And then I talk to the patient. I say, let's talk about, I really like you to make sure you're up to date with your vaccines. Have you had your shingles? Have you had your RSV, COVID, flu, pneumococcal? Your pharmacist is going to talk with you about it. And I'd say even if you don't have prescribing pharmacists, if that's not a possibility in your province, they can still have the discussion and they can still go through and see, what's there, what's missing. And then the physician maybe is too busy to do that. And the patient doesn't remember. I don't remember if I had shingles vaccine. I'm not sure if whatever. The pharmacist can probably find all that information for you.
Great point. Well, as obviously our next step as we reached the conclusion of tonight's program, and I want to echo Sue's comments as well as give our huge thanks for such an excellent presentation and fabulous insights, to say the least, is that every endocrinologist is different. And so we don't want, some overarching approach or sort of broad recommendation. Hopefully we'll get to that. Hopefully we'll incorporate, some education, some handouts, some easily accessible macros and handouts into the EMR. That's easy stuff to do. But your pharmacist, at each site is eager, whether it's to incorporate vaccines, recommend vaccines, put it in your letter, recommend it to the family doctor, send a task for a prescription if you're willing, or for you yourself to obviously prescribe it, whether it's locally administered or at the local pharmacy. This is, obviously the breadth of things that you're able to do. And, at the site by site and at the discussion between pharmacist and endo or PA and pharmacist, that's something that, your pharmacist will probably be eager to discuss with you shortly. And you'll see lots more presentations like the one Sue just gave, lots of vaccine presentations by GSK as well as others, and even that ADA recommendation. We don't know what Diabetes Canada has planned, but we know that carried with it some very significant weight, particularly for the elderly affected with diabetes, as obviously Peter And Sue alluded to, it's a no-brainer if you're of a certain age and affected with diabetes. And tonight's program is accredited, so we welcome any feedback both about tonight's program and ideas for future recommendations. We know they'll be updating the pharmacotherapy chapter for Diabetes Canada. We hope that that'll be, visiting speaker series that we're able to bring you in the coming months. And Nikki will, of course, send everybody a certificate in the coming days. Just check the chat one more time. You can also access the certificate and evaluation in the chat or just scan the QR code. Sue, before I conclude, any final words for us?
Well, I saw there was so many people on the call tonight, so I know that there's a lot of interest and enthusiasm. And I think you guys are really unique that you have on-site pharmacists who, really can, I think that might be one of the key directions you might want to consider taking, as you mentioned, Alex, to really integrate this into your practice.
Thank you again so much for presenting tonight. You did a fantastic job, and we'll wish everybody a fantastic evening. Good night.
Wonderful. Thanks, everyone. Good night.
And you can beam me up now, Scotty. Good night, Sam.
I just got out of the brig,
You
actually.
got what?
I just got out of the brig.
Yeah, you can tell.
Yeah, now I'm back
Okay,
on the
we'll get you Peter's Corona vaccine.
Yeah, that'd be great.
That'd be great
Okay,
for the
that's
beach.
great
Great job,
talk.
Nikki. Good night, all.
Good night. Thanks, Nikki. Ciao.
Have a good night, guys. Take care.
Bye.